Hi, I'm Claren, a speech and language therapist working in stroke care, and I'm going to talk to you about swallowing difficulties in stroke. Speech and language therapists, also known as SLT or SALT, are professionals who assess and manage swallowing difficulties. More than half of all stroke patients will experience swallowing difficulties. The medical term for swallowing difficulties is dysphagia, not to be confused with dysphasia, which is an acquired language disorder, also found in stroke. Dysphagia is a potentially serious complication of stroke, and if not managed correctly, can result in a form of pneumonia called aspiration pneumonia, and in some cases death. Some facts about swallowing. We swallow more than 1,000 times a day. We stop breathing for a short time when we swallow. We produce about 2 litres of saliva a day. We swallow our saliva approximately every 1 to 2 minutes. And there are over 50 pairs of muscles and 6 cranial nerves involved in swallowing. And swallowing is located in both hemispheres of our brain, but we have one hemisphere that is more dominant, and this varies from person to person and is unrelated to your handedness. Eating and drinking are really important, and it's more than just swallowing. Food keeps us healthy, it makes us happy, it's a way that we show we care about somebody. For example, we may take someone some fruit or some chocolate when they're unwell, we might make them a cup of tea if they're upset, and it's a way that we socialise and is part of family and religious occasions, as well as being part of our daily routine. This video shows what happens with a normal swallow, and what happens when someone has dysphagia and drink enters the airway. The diagram on the left shows a normal swallow, and the diagram on the right shows aspiration, so an abnormal swallow. While eating and drinking feels very automatic, we actually need a number of skills to be able to do this correctly and efficiently. We need certain cognitive skills to be able to recognise that we're hungry or thirsty, and we need to be able to plan and execute the preparation of food and drink, as well as knowing what to do with it when it reaches our mouth. We also need motor skills, which are important for preparing food, to be able to self-feed, to sit upright, and to chew and swallow. Sensory skills to be able to see, smell and taste food and drink, and communication skills to be able to request, order, state preferences of food and drink, and all of these skills can be affected by stroke. There are 4 stages to swallowing: the oral preparatory, oral, pharyngeal and esophageal. SLTs only deal with stages 1 to 3, and anyone with an esophageal difficulty will be managed under gastro. Stage 1 is known as the oral preparatory phase and involves being able to get the food and drink into the mouth and the initial preparation of it. Food and drink are manipulated in the mouth and chewed if necessary. The type of movement depends on the consistency, and the lips, tongue and palate work together to keep and control the food and drink in the mouth. The time needed for this stage depends on what you're eating. So, for example, you need more time to prepare an apple than you do a yoghurt. Stage 2 is the oral stage and involves being able to move the food and drink to the back of the mouth once you're ready to swallow. The lips and jaw are closed and there's tension in the cheeks, and this stage is under our voluntary control and it takes less than 1 second. This slide shows both the oral preparatory and oral stages, and the orange in the diagram represents the food being eaten. Stage 3 is the pharyngeal phase. In this part of the swallow, the soft palate lifts, the walls of the throat constrict, the voice box and throat move upwards and forwards, the airway closes, and the esophagus opens. And this phase of the swallow, it's a reflex, but it's also a neuromuscular pattern sequence response, as we use a different swallow depending on what we're eating or drinking, but we also swallow in our sleep, which isn't under our conscious control. So a good analogy is if you think about opening a door. If you know the door's really heavy, then you put more strength behind your push to open it, whereas if you know the door is lighter, you reduce the amount of effort involved. So your brain adjusts and chooses the right motor pattern depending on the door. And it does a similar thing with swallowing, so depending on the food and drink items that we're having. And if we use the door analogy, if you select the wrong motor pattern, you either can't open the door, or the door swings open very fast and uncontrolled. The final stage is the esophageal phase, and here food and drink move through the esophagus and into the stomach. It's automatic, so it's not under our voluntary control, and it uses peristalsis and gravity and takes between 8 and 20 seconds. This slide shows the pharyngeal and esophageal phases, again with the orange representing the food being eaten. And this video shows all stages of the swallow as they would occur in a normal swallow. A stroke can cause difficulty at all stages of the swallow, so we'll have a look at each stage and look at what issues we may expect to see. In the oral preparatory and oral stages, we may see reduced tongue movement, which would mean difficulty controlling the food in the mouth, and we might also see drooling. Reduced muscle tone in the cheeks, which would result in food pocketing or food residue left in the mouth after swallowing. Reduced lip closure, so you might see food falling from the mouth or drooling again. And reduced sensation, so the patient may be unable to feel where the food and drink is in their mouth, as well as any residue that might be left after swallowing. Pharyngeal stage difficulties can present in a number of ways. So someone may have no swallow at all, which would result in aspiration. And aspiration in this context is when food and drink enters into the lungs. They may have a delayed swallow, so usually when we swallow, the pharyngeal phase is triggered when food and drink moves past our tonsils. So there are varying levels of delay, so a mild delay could be the pharyngeal stage triggers just after the food and drink has gone past, or there might be a severe delay in which the food or drink sits in the throat for a few seconds or even minutes before a swallow is triggered. You may see reduced laryngeal closure, so usually when we swallow, our voice box moves up and forward and closes off the entrance to our airway. If this action is reduced, then it leaves the airway unprotected and aspiration can occur. And finally, a poorly coordinated swallow. So this means that the sequence of events that happen in a swallow are out of sync, and this can result in residue in the throat as well as aspiration. Looking now at the signs of a swallowing difficulty you may see. So we've got choking, coughing or throat clearing related to eating and drinking, drooling, weight loss, dehydration, aspiration pneumonia, recurrent chest infections, an increase in chestiness after food and drink, taking a long time to eat, food coming down the nose, pocketing of food in the mouth or food left in the mouth after swallowing. The patient is reporting having difficulty, an increase in shortness of breath, an increase in breathing rate, particularly after food and drink, and changes in voice quality, such as a wet, gurgly voice. So there are many signs of a swallowing difficulty, and patients can present with any number and combination of these. It's worth just mentioning silent aspiration. So this term is used when food and drink goes into the lungs, but the patient shows no outward signs of this. So they wouldn't show any of the signs of aspiration we've just mentioned, except for aspiration pneumonia and recurrent chest infections. And the only way to confirm this is by video fluoroscopy, which is essentially a moving X-ray of somebody's swallow. Aspiration can also result in longer hospital stays, more frequent hospital stays, and also an increased risk of death. So dysphagia does impact on nutrition, so some of the things you might expect to see are dull, dry or thin hair, poor skin condition, chapped, swollen lips or mouth, bleeding or receding gums, sores on the tongue, tooth decay, weight loss and muscle wasting, brittle flaky nails, irritability and confusion, and lethargy. It also impacts on hydration, so you might see a kidney impairment, dizziness or feeling lightheaded, impaired cognition and confusion, tiredness, dry mouth, VTE acutely post-stroke, and death. And it's worth remembering that patients on thickened drinks and modified diet are at increased risk of malnutrition and dehydration, so it's really important to provide extra encouragement for these patients. Mouth care is really important for all of us, but it's really important for stroke patients. Every patient should have a weekly mouth care assessment and plan, and just think about for yourself before cleaning your teeth in the morning how much better your mouth feels after you've done that, and how much it can sort of add to your sense of well-being. So mouth care is important for quality of life, dignity, hygiene, comfort, and the prevention of illness and disease. So aspiration can occur if bad bacteria in the mouth is inhaled, which can result in an aspiration pneumonia, and in some cases bloodstream infection. Patients who are ill by mouth can still get an aspiration pneumonia, so it's important to know that that doesn't just come from food and drink. And poor mouth care has been linked with cancer, diabetes, stroke, cardiovascular disease and dementia. And for more details on this, please see Mouth Care Matters and also your trust policy on mouth care. So there are a number of things that you can do to help somebody with a swallowing difficulty. Firstly, ensure that they are awake and alert. If they need glasses or hearing aids, make sure they're wearing these. Make sure their mouth is clean and clear of any debris or secretions. If they have dentures, make sure these are clean and secure in the mouth. Ensure that they are positioned upright as possible in the bed or chair, following any physio recommendations. Reduce any distractions, so sort of turn off the TV or the radio. Have good lighting, so they can see what they're eating, and if they're visually impaired, to help them what they have on their plate. Use the correct utensils, including any adapted cutlery or plate guards, and follow any OT recommendations. Ensure the patient has the right cup by checking the SLT recommendations. We sometimes state that patients should have a small hole beaker, or no lid on the beaker, or that they need to have their fluids via teaspoon. And these recommendations are made to prevent aspiration, so it's really important that you follow that patient's guidance. Orientate the patient to their meal, and this is particularly important if the patient has cognitive difficulties or is confused. Tell them what they're eating, especially if they're on a modified diet, as the food can sometimes look different to what they're used to. Ensure the food is hot and is the correct consistency, and you'll need to check the SLT recommendations for this. Ensure the patient has fresh drink of the correct consistency, and you will again need to check SLT recommendations. And thickened drinks can become very unpalatable if they're left out. So if you wouldn't drink it, then please don't expect your patient to drink it. And if the patient is having a cold drink, if possible and if the patient wishes, if you make it with chilled water, or you have it chilled, as this makes the thickened drinks more palatable. The patient may need physical assistance, as stroke often results in paralysis or weakness down one side of the body. This means it would be difficult to hold cutlery, cut up food, get the food onto a forkful spoon, and then get it into your mouth. Follow the SLT recommendations for timing. So, for example, we sometimes recommend that you need to leave sort of 30 seconds between each teaspoon or each mouthful, and just remember that taking longer to chew and swallow are part of having dysphagia. Follow any other SLT recommendations. For example, we may state that somebody needs hand-over-hand assistance, and this is important as the person's brain gets signals from using their own hand or arm that food is on the way. And research has shown that this alerts the swallowing centres in the brain to prepare to swallow, so it can have a real impact on the effectiveness of somebody's swallow. If you're assisting with feeding, sit in front of the patient so they can see you and you can offer food head on. Think about how you normally present food to yourself. Often people will stand to the side of a patient, and this means the patient cannot see you, and also that the food will go in at an abnormal angle. You'll come across IDSI, which stands for the International Dysphagia Diet Standardisation Initiative. And this means basically that everywhere in the world the same consistencies and terminology are used. And it consists of 8 levels. Levels 0 to 4 are drinks, and levels 3 to 7 are the diet. And your patient's recommendations will always relate to these levels. This diagram illustrates the IDSI levels, but please see the IDSI website for more details. So in summary, the normal swallow is made up of 4 stages. Swallowing stages 1 to 3 are assessed and managed by SLTs. Dysphagia is any impairment in swallowing. More than 50% of stroke patients will experience dysphagia. Dysphagia can have serious complications such as pneumonia and death. Good mouth care is really important. Diet and fluids are standardised using the IDSI levels, and there are lots of practical things that you can do to help somebody with a swallowing difficulty. And if you have any further questions, please speak to your local SLT team. Thank you.